designated inmate unit for 2 days. And I stayed there for about 5 years until I was recruited to Lennoxville, because by that time we knew that on any given day, hundreds of patients with AIDS were hospitalized in New York City. I'm just going to go back to the late 70s. We were taking care of AIDS patients back then, although we did not know they had AIDS. As we looked back on our history together, Valerie and mine, we realized how many patients that we actually did take care of that we now know in retrospect had AIDS. So throughout the 80s, these people lost their jobs, they lost their homes, they lost their families. Often they were outed at the same time as they were diagnosed. When I joined St. Clair's Hospital in 1985, Mother Teresa had furloughed 3 inmates from Sing Sing prison and brought them to St. Clair's. Those were the first 3 patients that we opened the unit with, and I was fortunate enough to take care of all 3 of them. So there was a lot of news hype about that. Mother Teresa was at St. Clair's, Archbishop O'Connell was at St. Clair's, and we ran that center until such time as that center had closed. So that, all of that time between 1985 and 1990, when Valerie and I were there, that's all those patient stories will be in the book. But I want to start out with telling you one particular story. I want to draw your attention to this young man. This young man is David, and that's me, by the way, with my afro. That was at the AIDS Walk in 1986. David was a 26-year-old, he's 21 there. He's a 21-year-old who came from England to follow a boyfriend here to the United States. When he got to the United States, the boyfriend had already been in a new relationship and wasn't interested in David anymore. David came to the emergency room at St. Clair's Hospital complaining of what we call typical symptoms back then for HIV. He was short of breath, he felt the palpitations, he didn't feel well. Anyway, it turns out he wasn't sick. He just was having a panic attack. And when they ruled out all kinds of infectious origin for his symptoms, they wanted to discharge him. And he had nowhere to go. So he told them that he would kill himself if, in fact, he was discharged to the street. So he ended up as a patient on our unit, where I got to know him over the course of a few months. He was not sick, he was just anxious. And back then, you didn't have emergency Medicaid, there were no social work service, there was no case management services. He did not qualify for any kind of services to help him get started in the community. So he was told, well, you should go back to England. He did not want to go back to England because his family didn't want him. His family, and this is a quote, his family wanted a real boy, and he was not. So he remained in the hospital. I got very close to him. I used to chat with him every day because by that time I was a supervisor there. And what ended up happening was I took him home with me and let him live with me and my husband in our 1-bedroom apartment in Queens for several months. Don't ask me why. I mean, would I ever do that today? No, but seriously, I just got so attached to him. He did live with us for a few months. It did get a little hairy at times. We got him some jobs cleaning apartments. He then started to go out to the one gay bar there was in Queens where he met somebody. He moved to Jersey. I thought he was set, he was great. He then visited me in 1992 after I had my daughter. He came to visit me in Queens. I hadn't seen him for a couple of years. And he told me he was HIV positive. I said, are you okay? And he said, yeah. Anyway, one day, somewhere in the 1992-ish, his partner, Victor, called us and said, David wants to say goodbye. And I said, what do you mean? He said, where are you going? And he got on the phone. David was in the hospital with cystic pneumonia. And he said, I didn't want to leave this earth without telling you goodbye and thank you for all you did, because if it weren't for you, I wouldn't have found the love of my life. He died at 26 years old that night. These stories are over and over. You know, we hear these stories over and over, and we did hear these stories over and over again. And I'll probably tell you one more, but we encourage you to look at the book. We have Instagram, Nurses on the Inside. Please feel free to follow us. But I'd like to turn it over to Valerie, because Valerie's been a nurse practitioner for 20 years in AIDS research. And she's going to give you a little bit of insight into what's been going on and what happened back then. So let me turn it over to Val.
Thanks so much. So I'm going to just put my slides up real quick. Long. Oh no. I did something wrong. Well, anyway, let me just move on. So, my name is Valerie Hughes. I'm a nurse practitioner. I think it's always a good idea to know what my credentials are, because you know Ellen very well, but you don't know me at all. My original degree was an associate's degree from Queensborough Community College. I worked as a registered nurse for 10 years before going for my bachelor's degree at Pace University, Ellen and I were together. And then subsequent to that, I went to Pace again for my FNP. And I did that because I was running a clinic, and I realized that I could be more effective if I actually would be able to diagnose and prescribe. So that's sort of been the trajectory of my academic career. I look at you and I see that you're on the first rung of your academic career, and I have to say that I am so happy to see you do this, because we really do need compassionate and skilled nurses. You know, as I age, I realize that I'll be needing compassionate and skilled nurses as my time moves on. But I also think that it's a wonderful career, and for all these years that I've been a nurse, I've never been sorry that I made that decision, because there's such a huge diversity of choices for you to choose from, different kinds of careers. Mine happens to, the overwhelming intellectual interest of mine has been HIV since my first HIV positive person. And so what I'm going to try to do in my little short talk about this is to give you some perspective about the history of HIV. So some of them are personal stories, and some are from the archives. Some are going to be the archives not being textbooks, because back in those days there were no textbooks. All we had were publications that were being published either weekly or monthly, and because nobody had any idea what was going on at the time. I'm also going to do a couple of drug development milestones, and but we're not going to be able to go through the life cycle, and certainly won't have time to play Jeopardy, although that's always fun. So from the textbooks, and from that I'm talking about the Morbidity and Mortality Weekly Report, which is something you've probably never seen, and up until this time was something I never paid attention to, although I knew it existed. It actually reported a new incidence, seeing these new incidents of Kaposi sarcoma, which is an HIV-related malignancy, and pneumocystis pneumonia. So pneumocystis used to be called PCP, pneumocystis carinii pneumonia. It's now called pneumocystis jirovecii, and I'm not really sure why they changed its name, but it's the same disease. When you talk about pneumocystis PCP, it's the same thing. And this didn't happen until 1981, even though Ellen and I, in 1979, we think we took care of 2 people for sure who had HIV in retrospect. But the rest of the world wasn't understanding what was going on. We were all seeing things in little isolated pockets, and we really did not have a mechanism for speaking to each other. No internet in those days, no cell phones, no social media. So there was nobody to sort of post, oh, I saw this peculiar case of pneumonia, or this peculiar violet cancer lesion, which I don't know what it is. And it turns out to be something that only elderly Mediterranean men get. So really in those days we were very, very isolated. So in 1981 were the first official reports, as I said. And first they saw that this was occurring in men who have sex with men. They also started seeing it in sex workers, female sex workers. and in people who inject drugs and were sharing needles, and they were also seeing immune suppression. So they realized at some point, although not in 1981, that it was bloodborne and sexually transmitted. In the beginning, if you see people with this infection, it starts to make you think, oh, maybe it's airborne, TB, or maybe it's contracted in some other way. And so people got completely bent out of shape about this. I can't begin to tell you. People would not go into the rooms of people who had HIV. If they knew that it was a gay person, they would not bring food into them. They wouldn't empty the linen. They wouldn't go in for hours and hours at a time. And a lot of times these were the people who were most in need of nursing attention. In 1983 and 84, first the French isolated what HIV was, and then the Americans did. And by 1985, we had an antibody test. So you know the difference between antigen and antibody. Antibodies are your body's response to seeing a germ. Antigen is the germ itself. So all we had was an antibody test, which was a pretty good test, because prior to that, there was no way to protect the blood supply. So people were donating blood, there was no way to test it for HIV as well, which was another major way that HIV became disseminated throughout the United States and, of course, the world. And, of course, people who had to have blood or blood products on a routine basis, mostly hemophiliacs, they got a huge load of HIV along with their factor VIII. And so that ended up being a huge risk for acquiring HIV. By 1986, they figured out that there were two subtypes, HIV-1, which was predominant in North America, and HIV-2, which was predominant in sub-Saharan Africa. But it wasn't until 1987 that the first drug to try to fight HIV was approved for use, and that drug was called AZT, or zidovudine. So this is a snapshot of the MMWR report from June 5th of 1981. And you've heard that referred to a couple of different times. And that was a very important milestone for starting to disseminate the information about HIV. Then in Los Angeles, they started to have reports of this also. But I just want to point out one thing about HIV, and that people think of HIV, oh, that must be San Francisco, Miami, Los Angeles, but New York was the epicenter of the epidemic, with more patients by far than Miami, Los Angeles, and San Francisco combined. Because New York is one of the biggest cities. We have over 8 million people here, and even then we had over 8 million people. So when you have that many people, that's what drove the numbers. So even though you will see a lot of information from California where people were more vocal and more accepting, or at least more vocal, definitely, New York was by far the hardest hit in terms of how many people were treated on any given day. So in July, they started to report these incidences of the rare cancer, which was Kaposi sarcoma, a very vascular cancer. And I'm going to show you a picture of it in a minute. And then the CDC in Atlanta started to get into the act, which we sort of wondered, some of us wondered, when was that going to happen? Because you sort of think of the CDC as being the absolute be-all and end-all of infectious diseases, and it is. And so they did their reports as well. So I'm going to show you a few pictures of what happens to people who are incredibly immune suppressed. Now, I want you to understand that some of these are extremely upsetting. They're very, I just find them also to be very upsetting. You know, in the clinical arena, you see things, but because you're busy working and helping, it's not so upsetting. Whereas sometimes when you see a photograph of something, it can be very upsetting. So if you aren't a clinical person or you think you'll be upset, it's probably best not to look at these following photos. The first one is a picture of a person who has basically 0 T cells, and this is nothing more than herpes simplex that's taking over his face. All right, and I've taken care of people who had this herpes simplex type 2 genital that took over everything from the waist down, because there is no way that your immune system, or that your body can fight off this kind of virus without any CD4 cells, all right? CD4 cells are the commander-in-chief of the immune system. All right, the next one's pretty bad too. This is molluscum contagiosum, which is another viral infection. It causes bumps. If you were to unroof the bumps and take what's on the inside out, it would be a little pearl that's teeming with virus, teeming with it. And this is incredibly contagious. It's possible for those of you who have done peds, you might have seen a baby that has one or two, because babies have sort of incompetent immune systems, and so you do sometimes see this in babies. But, you know, after they're about 5 months old, no, you would never see this again, and you would never see this in an adult unless they were severely immune compromised. This next one is a picture of the Kaposi sarcoma that is not only outside but inside. So this is causing problems with lymphatic drainage. So the lymphatics are in the neck and help to drain fluid out of the face. And this person is having involvement with those internal structures, and it's causing that periorbital edema that you see there. And of course you can see the violet lesions on the side of his face. So he also has very severe inner KS, which was affecting his lungs, and ultimately he died from that. This is what it looks like when it's confined to the skin. This is cutaneous KS. And then this is a terrible case of cutaneous KS, but which actually got much worse. These are not only sort of blister-like lesions that happen during the early stages of the cancer, but later on, this can become very hardened, very leathery, very obstructive. And you say, well, if it's a cancer like that, why can't you cut it out? Because it's also filled with blood vessels, so resecting it is almost impossible. You have to treat it with chemotherapy. And Susan Crown at Memorial Sloan Kettering was the person who gave me that slide, and also was the forerunner of oncologists who were treating KS in the early 80s. This is a picture of oral candidiasis, which you might have seen also in infants. Also, once again, infants can get it because they're immune compromised, or I should say immune immature, not compromised. But this is an adult, and you never ever see this in somebody who is not immune compromised. Now, sometimes you'll see it in the very elderly who are on big antibiotics and big steroids, but that's what steroids do. They tamp down immune response. Okay. This is just a sticky note that was written by a colleague of mine back in the day, trying to keep track of surveillance rates in New York. And he's a guy named Ken Sepkowitz that I don't know I worked with back in the 80s. These were the original stories that we were going to talk about, so I'm just going to pause here to talk about one of my patients, not one of those listed there. And I'm going to call her Ella. And Ella was a woman who had a very raggedy life. She was raised in poverty, basically, and was sexually abused as a child, and when she got away from her household that was the source of her abuse, she became an injection drug user and acquired HIV. Along the way, she did have a child, and she really was unable to take care of him, and she left him to her aunt. Her aunt ended up raising her son. So when she was about 27, she came to us at Lenox Hill, and she was already pretty sick. She'd had pneumocystis a couple of times, and she developed something that only happens to people with advanced immune deficiency, something called cytomegalovirus. We've all been exposed to CMV. We probably all have antibodies to CMV, but with our intact immune system, what happens is that if it tries to reproduce, our immune system says no. But in somebody with no immune system, and Ella had about 4 T cells at the time, it was able to pretty much do whatever it wanted to. CMV can affect the lungs, it can cause pneumonitis, it can cause gastritis, colitis, all sorts of itises, but the worst one is retinitis. It actually affects that little tiny thing, that 2 millimeter square thing in the back of your eye that allows you to see. And it was one of the most devastating illnesses that we saw. So the treatment was an antiviral that had to be infused. But what ends up happening with the eye is that the eye is largely cut off from the rest of the body in terms of vascular access. So there's not a lot of blood that goes to the retina. The retina is kind of avascular in a way. And so after a while, that didn't work. So we give the highest doses we possibly could, which also was very damaging to other parts of the body. And ultimately, the ophthalmologist decided that she had to get injected directly into her eye. So I was the clinic nurse then, and when it was part of my responsibility to make sure that that stuff happened, but also she was so scared, and frankly, I was so scared also, because anything to do with the eye sort of terrifies me still to this day. But I went with her while she was having her injection, and after the first one, I thought, how did she go through this? They actually put a needle in her eyeball, and she had to go through it again and again and again. And after a while, I said, Ella, why are you doing this? And she said, I can't die, I can't go blind, I have to see my son grow up. I have to live. I want to see him graduate from high school. I want to see him get married. And I said, all right, well, I'll do what I can. And we did what we could to try to keep her alive. I could tell you that she did get to see him graduate, but she did not get to see him married because she died of her 5th bout of pneumocystis pneumonia because she also had allergies that made prophylaxis difficult. But I have to say that she was one of the bravest people I ever met. She determined that she was going to go through whatever she had to go through to try to survive. And that was a huge deal. But she was 29 when she died. Right? She was 29. So that's the one story that I wanted to tell you about. I think Ellen has one more that she wants to tell you about that is particularly close to both of us, somebody that we both knew very well.
I'm just going to escape this.
Oh, here, let me do that.
So let me just start here. These are some of the faces of AIDS that I think you all should see. This is Gary. He was 34 when he died. This is Danny. He was 32 when he died. This is Claude. He was 42 when he died. This is Ben. I'm going to tell you Ben's story. He was 39 when he died. These were all in the 90s. That was me, and I'm still here. This is Jim. He was 42 when he died. This is Fred. He was 48 when he died. So I want to go back to this slide. So I'm going to talk about Ben. Ben was a nurse at Lenox Hill Hospital. He was working on the 4th floor, which was just a regular med-surg unit. We had our AIDS Center program on the 8th floor. And he had put in for a transfer to the 8th floor many months. And everybody wanted to work on the 8th floor because by then we had a lot of people that were very concerned and very involved in the epidemic. Volunteers, we raised a lot of money for the patients. But Ben transferred down probably in 1995-ish, and he was a great nurse. Very, very relaxed with his patients, very comfortable, very interested. Now Ben, he was kind of a stockish young man, and he always used to wear like white baggy trousers, and he wore a white button-down shirt like you'd wear under a suit. And although that wasn't standard uniform, we didn't wear scrubs back then, we wore regular white uniforms. I always thought to myself, gee, he looks always dressed up. So anyway, it was within the guidelines of uniform, so he went on and on. Well, back in the 90s, I had been doing a series of seminars on training and coaching, and a lot of the staff back then that worked with me wanted to do these seminars as well, and Ben was one of them. It's a weekend-long seminar that's supposed to just give you a new, like a paradigm shift in your life, and I was very involved back in the 90s and early 2000s in this work. And Ben said, you know, you're like a different kind of manager, Ellen, and I just want to know what you do. So I told him about these seminars. So he went to a weekend seminar. And so I used to go to the graduation night of this seminar, and I did. It was a Tuesday night, and it's down in the 30s by Madison Square Garden. And there's always Tuesday night when they have this called the Landmark Forum. There's a lot of people spilling out into the street, and they're all hugging, and there's like a lot of love all over the street, and people are just congratulating each other. And I was looking for Ben, and when I finally found him, there were people surrounding him, hugging him, saying, thanks for the share, God, you're great. And I went over to him and I said, Ben, what's going on? Well, he picked me up and he swirled me around and he said, Ellen, I'm gay and I have AIDS and I'm free. Now, he had hidden this for so long. He had one of the worst cases of KS that we've ever seen. The very next day, that was a Tuesday, this was a Wednesday, I walked into work, and my staff came running up to me, and they said, Ellen, Ben's in room 814. I said, what do you mean? He's off today. No, he's not. He's a patient. Well, after that, I guess his immune system just took a sigh of relief, and he came in as a patient. He died within a few weeks. He had such advanced KS, I can't even imagine how he was walking. All those pictures that Valerie showed you, he had all of that. So he died probably a few weeks later. He was too advanced for chemotherapy. He was very malnourished, even though he was a big guy. It's because he was so swollen from all the KS. So he died in 1997. He had told us all he had a wife that she lived in, I think it was Haiti. He was going to send for her. He was going to send for his children. Never let on. Back then, in the late 70s, early 80s, being gay was not talked about. You just didn't talk about it. It ruined your life back then. And I guess even though that he was in the confines of a unit that would accept him, he was not ready to let us know who he was. But after doing this, he did die a free man. As sad as it was, he died being who he was and surrounded by the love that our unit was able to give him. And again, that story is also in the book. But when you look at all these people, you have a generation that never got to live, never got to have children, never got to have grandchildren, never got to tell their story. And that's why we're going to try to tell it for them. So I'm going to turn this back over to Valerie, who's going to talk for just a few more minutes about therapy, and then we'll take your questions.
Thanks. I think that it's sort of an interesting thing about those of you who are not gay probably don't understand what it would be like to confess something to people who are either not just strangers, but I'm just going to tell you a quick personal story about that because I'm gay, and Ellen's my best friend, and I didn't even tell her for a long, long time because I was so afraid of kind of stigma that might attach. I was afraid that she would not want to be my friend anymore, and so that's what kept me silent about it, and that's what kept Ben silent about it because he thought that he could not say who he was to us because we wouldn't accept him. He couldn't even tell another gay person that he was gay. And that must have been such a horrible burden to bear. Anyway, I'm going to go back to didactic slides. Here, I found it. Okay. Okay, well, these are just snapshots to tell you that women were getting it and children were getting it, and I want to talk about, that was transfusions, we already talked about that, but I do want to talk about infants a little bit, because I want to talk a little bit about a study that I was peripherally involved with called ACTG 076. That was where it was the first study that proved if we treated the pregnant woman and her baby immediately after delivery, that the baby was a hugely amount less likely to actually acquire HIV, because we really didn't understand the mechanism for how HIV was spread from a pregnant woman to her baby. We thought it might have something to do with the placenta, because, you know, even though you know the placenta is a terrific barrier, we thought that it was possible that the virus was getting in the baby that way, but that was not the case. In fact, almost all infant acquisition of HIV is acquired during the birth process, which, as you know, if you've ever seen a baby born or ever had a baby, then you know it's kind of a messy ordeal, and there's a lot of blood and body fluids that get exchanged between mom and baby during the birth process. And so 076 was a study where we gave women AZT intravenously during the birth process, which what we didn't know it was doing, because we didn't have a measurement for it back then, was that it decreased the amount of viral load in the blood. And then we gave the AZT to the baby for a few weeks afterwards. And so it decreased transmission from, you could guarantee that if a woman with a high viral load, but we didn't know that's what it was at the time, had a baby, that she would be almost 75%. The chance would be that she would pass it on to the baby. And it decreased by 2/3. So, in fact, right now it's almost impossible to find a woman who's gotten any kind of prenatal care who is transmitting HIV to her baby. So that was a huge thing, and it also set up the whole concept in people's minds about pre-exposure prophylaxis, or PrEP, which is something that's very much near and dear to my heart. I've already done 2 PrEP studies, been involved in 2 PrEP studies, and I think that we really have found a way to decrease the amount of HIV that's in the population. If we could do that, then, and decrease the amount of HIV that is spread from one person to another person, then we can actually try to fight it in terms of, almost in the same way we did measles, or back in the day, or smallpox. So that would be one way to eradicate HIV. The other way would be to find a neutralizing cure, which we're also working on. So we're working on both of those things. I'm going to go on to therapies. Now, a lot of things were tried early in the beginning, and they were found to be ineffective. And part of the reason for that is we didn't have the tools for measuring effectiveness. All we had was CD4 lymphocyte count. We did not have an HIV RNA, which is something that's really common now. That didn't get developed and widely used until November of 1995. And so before that, we were looking at CD4 count, but if you look at the CD4 count, we're looking in the rearview mirror, because whatever has happened to make the immune system drop has already happened. And so if you can actually treat the viral load and make the viral load go down, it might take weeks or even months for you to see a replenishment of CD4 cells. So if you already see very depleted CD4 cells, whatever has happened is, that's it. It's not going to get too much better than that, especially if you don't have effective therapies. And so some of these things, the soluble CD4, that was trying to block the receptor site that HIV latches onto, but they couldn't get good blood levels, so that didn't work. Compound Q was just completely ridiculous. I worked on something that was supposed to be an immune stimulant called Lentinan. We tried it on 100 people and it didn't work. So there were a lot of false starts and stops. But in 1994, well, I guess it was late 1993, David Ho from the Rockefeller Institute actually, by electron microscopy, figured out what was the life cycle of the virus. And then all of a sudden we had something to work with. Because then we realized that the viral, as soon as somebody gets infected, their viral load pops up, maybe even into the millions. And then after a while, it settles down to steady state. And the place where it lands in steady state is going to predict how quickly a person succumbs to immune suppression. So the higher the viral load, the more the immune system gets suppressed. Because the virus preferentially attacks the CD4 lymphocyte, the very commander-in-chief that might be able to fight it, but it's already suppressing the major immune cell that might help to fight it. So it took a while before we developed some meds. Now we have, I want my list of meds. I'm not going to talk about AZT too much because really nobody uses it anymore. It's historically very interesting, but it's not. It was never a good drug. I mean, it had a lot of toxicities. It was bone marrow suppressive. It caused nausea, hair loss, stomatitis, bleh, whatever you could think of that's bad about a drug it could cause. And the other thing was totally overdosed in the first years because it was tried at way too high a dose. So other drugs wandered in, but by 1992, we really only had a few drugs and didn't even really know how to use them. It wasn't until 1995 that we figured out that you had to use at least a minimum of 3 drugs, and you had to give them all at the same time. I can remember in 1991 going to a conference when Vidax was approved. They said, well, should we use AZT first and then Vidax, or should we use them together? What should we do? And really, people didn't think about combining medications. What they wanted to do was spin out the life cycle of being able to use drugs. And so they ultimately ended up deciding to go with guidelines that you start with AZT, then move to DDI, which was a very wrong choice to make. But in those days, we had no way to know whether our treatments were effective or not, because once again, all we could do was look at the rearview mirror. So the big change came about in 1995, November. I can remember it very well. Saquinavir and Lamivudine were released in November, late November of 1995, and that completely and totally changed the way we practice medicine. Also, HIV RNAs by PCR or viral loads were that particular lab assay was developed, and we were able to find out whether what we were giving people was actually working or not. All of these drugs have been developed, and all the ones that are crossed out are no longer in use very much. But you should understand that in the last 20 years, we went from giving 20 pills 3 times a day, and now we have no fewer than 6 one-pill once-a-day regimens available to people. So that the kinds of medications that we give now are a lot more tolerable. They're certainly a lot more effective. They have a lot more, much more barrier to resistance, which I won't get into resistance because it's a kind of complicated concept, but HIV can mutate around drugs, and so we have to have a high barrier to resistance. And so the drugs that are left over are the ones that are the most effective and have the highest barrier to resistance. And that's about it for mine. Because also I see that it is now 1:45, and I want to have some time for questions. Does anybody have any questions? Gosh, no questions. That's nice. I understand.
Yeah, well, it's Friday.
It's Friday. You guys want to get out and go have your 3-day weekend. I understand that.
Do you have a question, Ken?
Actually, yeah. Ben's story, you said that on Tuesday you saw him, he had the energy to actually lift, not that it takes much energy, but to lift you up. And
Yes, he did.
happy and
Yes.
out and about.
Yes,
And then the very next day he was in the hospital.
yes,
Chaos.
yes, yes.
Okay,
Cancer, yes.
right, but, I mean, were there visual, physical manifestations of his belief?
No, well, if you remember early on, I told you
He was covered.
he was covered. He was wearing baggy trousers and a long white shirt with cuffs
And always closed.
and closed. And nobody thought anything of it.
But even so physically, I mean, the downfall happens,
That fast.
that fast.
You know, there's something about, it seems, and it's really anybody's guess, but his immune system probably took a sigh of relief and said, okay.
So I have a little something to say about that. Have you ever been in a situation where it was a really bad situation, such as the near death of a loved one, or a car accident, or something that's really, really stressful? And afterwards, when things are okay and you can take a sigh of relief, then you get a really bad cold, or your cold sore comes out. That's what I think happens is that over time, your immune system is crapping out, and it gets to a point where it's just done. Now, we know that his immune system was bad, because when you saw his KS, that one that I showed you with the blisters, that was nothing. That was nothing compared to what he had, and it was everywhere. It was like a bark, it was like bark on his skin. And it was inside his organs as well. And I think that what Ellen is saying is real, is that sometimes humans can push through, we can push through, but there comes a time when we finally relax, and then it's time to go. And I think that's what happened to him. I think he was so relieved at being able to tell the truth for the first time ever.
you're studying for tests. You know, you're study. You're on, your foot is on the gas pedal, and then finally you come and you got a break, and guess what? You all get sick. You all get a cold, right? So,
If that's ever happened to you, you know that's what defense is.
question?
No, I don't have a question, but I just want to say, I had worked in a clinic, and they had an AIDS clinic, and very early on, and the patients would start, and within 6 months, they would die. It was really,
So that's about par for the course. The one final thing I want to tell you before I'm going to dismiss you for the weekend is that Valerie and I have been approached by somebody who works for the World Health Organization and lives in Kuala Lumpur, Malaysia. And Valerie and I will be doing a series of webinars because in other countries, they are where we were in the 80s and 90s. They are still there. There are still people that are not coming out, that are not getting tested for HIV, that are not getting diagnosed early, so getting treatment. So our book is going to end up being translated into Malay and get there as a teaching tool. So we have to realize how lucky we are that we moved forward. But there are still countries that are not there yet. So, but anyway, thank you so much, and you guys have a great weekend. Enjoy your extra day, and it's on Tuesday. Yes.